talk to you today about is our healthcare system, our achievements, our challenges towards the future and currently, and our opportunities. So what I'm talking about is the Costa Rican Healthcare Authority, what we call the Caja Costarricense de Seguro Social. This is an institution that was founded in 1941. It was the result of a three-way negotiation in a very turbulent decade, politically turbulent. And this negotiation took place between the party in power at the time, the Communist Party in the opposition, and the Catholic Church. So if you can imagine that three-way negotiation taking place back in the 1940s, that is what created what we call today our social guarantees. And public health for the workers was one of those guarantees. So we can see it was founded in 1941. In 1947, we added pensions as one of those guarantees. So the same institutions not just funds, but also provides health care, as well as managing the largest pension system in the country. By 1961, it was declared that our goal would be universal health care coverage. So it started out just covering workers, and then it was expanded in steps over 18 different administrations through today to what we have today, which is essentially universal health care coverage. And then we had some consolidation in the system where hospitals that were managed by the Ministry of Health were transferred to the Healthcare Authority, and then some improvements later in the lifespan of our institution. But this is one of the most important institutions in Costa Rica. Now, the coverage of our institution is very broad, not just in terms of the fact that everyone's covered, but they're covered where they live. 99% or over 99% of our territory is covered by our institution. This is not an easy task. There are regions in our country which are very mountainous, way up in some regions of the country that are surrounded by jungle. These are indigenous territories that you can only reach by helicopter. And when you go there, you will find a clinic with a dental chair and medical staff servicing our indigenous population. This is one of the big achievements. It's been a process to get to cover our entire country. And it is the presence of the state in some of the most remote areas of the country. In many countries, the presence of the state in the most remote areas might be the Army or another institution. In our case, it's usually either a healthcare clinic or a school. The services provided by our institution are therefore healthcare. Once again, it not only finances, it owns and operates all our clinics and hospitals, our pension system, and social benefits, primarily for the elderly. So the infrastructure we've built up over these last 78 years is the following. We have 29 public hospitals, 106 what we call health areas. These are essentially secondary level of care clinics. There are some surgeries that take place in these clinics. Some specialties are offered. And then we have 1,048 primary care clinics spotted around the country, and 489 centers for periodic visits. These are some centers that are not permanently staffed, but that we visit periodically, about once a month, to care for the local population. These are some numbers on the production of what our system produces in terms of healthcare output. We have, as of 2017, we were generating 255,000 hospital discharges per year, 5.7 million patients served through urgent care, 13.3 million doctor visits, either to a general practitioner or a specialist, almost 85 million drug prescriptions, and 57.7 million lab exams. This is pretty intense healthcare services for a small country of only 5 million people. Now, the outcome of this has been one of our biggest achievements. We have a life expectancy at birth of 80 years. This puts us on par with most developed nations. These are rich nations. We are a middle-income nation. So our model has allowed us to have health indices of a rich nation without yet being a rich nation. We spend about 10% of our GDP on healthcare. We have a healthy life expectancy after the age of 65 of 19 years. Child mortality rates of 7.8 per 100,000 births. A human development index of 69 out of 188, and maternal mortality of 2.8 out of every 10,000 births. Now, the life expectancy story is very interesting because although we already have a long life expectancy at birth, that gets extended as we live. And this happens everywhere in the world. The older you get, the more you can expect to live, not because your biology has changed, but because you're in a new average. Some people have passed away. They were part of the average that was computed into that life expectancy at birth. But in Costa Rica, this extension of life expectancy as you live is very disproportionate, to the point where 90-year-old Costa Ricans have the longest future life expectancy in the world. And to be frank, we don't know why, but it's a fact. And so this is a big success, but it's also a big challenge, and I want to go over some of the numbers. So one of the biggest drivers for healthcare demand growth as we move forward is an aging population. We have one of the fastest aging populations on the planet in terms of how long it takes for us to double our population over 65. Here are just some parameters of our population. We have about 11% of our population is over 65. It's a little over 550,000. That is going to more than double to 1.26 million by 2050. Now, this is big news when it comes to healthcare utilization. This slide, I'll explain. The area of this rectangle is proportional to the number of hospital stays in terms of overnight stays in a hospital in our entire healthcare system. And we've divided it in columns by different services, whether it's obstetrics, psychiatric care, pediatric surgery, with the width of this representing the proportion of the total number of hospital stays. So what we call medicine is the widest one, so it's the most important one. And then the colors represent the different age brackets. So you can see in orange that half of all of the hospital stays in our most important hospital service is consumed by people over 65. So half of hospital demand is consumed by 11% of the population. And that bracket of our population is going to more than double over the next 30 years. So if we project this to 2050, we go from what today is 1.9 million hospital stays to 3.2 million hospital stays, where 70% of those hospital stays are being consumed by people over the age of 65. This is a major, major challenge for us. It has taken us 78 years to build the healthcare system we have today, and we have to more than double its capacity in less than half the time it took to build this healthcare system. Plus, our disease profile has completely changed. We used to die of acute diseases. You either got better or you passed away. Today we have heart disease, we have cancer, we have injuries, diabetes, other non-communicable diseases, chronic respiratory diseases. These are the major burdens of disease today. And essentially, we all live with our diseases. These are risk factors of our population today. We have obesity, smoking, a sedentary lifestyle, traffic accidents, a homicide rate, and a suicide rate that has been on the rise. So these are all risk factors that drive more demand within our healthcare system. And then we have what we call the judicialization of health. In Costa Rica, we have a constitutional right to health. That means that if any citizen is not treated for what that citizen has with the treatment that that person needs in a timely manner, that person can go to the Supreme Court and their cases will be reviewed within days. And a ruling will be issued which mostly favors that patient or that person. And so this has caused a large flow of patients that are demanding very expensive care, whether it's very expensive drugs or very expensive types of surgeries, to enter into our system. This is a graph of suits filed against our authority, our healthcare authority, for access to certain types of drugs. And you can see how this is certainly on the rise, with the red bars including those that the patient won, and the green bars, those cases that the patient did not win. Now, just to give you an idea of how expensive these drugs can be, here are just some examples. For diabetic patients, we can cover 100,000 diabetics with insulin that is costing us $5.4 million per year. So that's an average cost per diabetic of $54. We can cover 1 million patients with antidepressive drugs for $5 million, for a cost of just $5 per patient. But of those court cases that we get of people that are suing for access to the more expensive drugs, just 3,960 patients cost the system $56 million in drugs for an average cost of $14,000. We have drugs that are covered by our system that cost over $100,000. And so these are all strains on our system as we get older, as we have chronic diseases, as we have poor, unhealthy lifestyles, and so forth. Here's an example of our drug budget for our pharmaceuticals. So back in 2007, it was $100 million, and as of last year, it was $250 million. So it's growing fast. And what we have between these two, the two colors are, in orange, small molecule drugs. These are drugs that would be like a statin for cholesterol or a hypertension drug. And then in blue are the biologicals. These are products of biotechnology. They can be monoclonal antibodies for the latest cancer treatments or multiple sclerosis drugs. And these tend to be very expensive drugs. And you can see how this is becoming much bluer. So a greater and greater part of our growing budget is being consumed by these more expensive therapeutics. Now we have some financing challenges, and that is there is a slowdown in contributions into the system that are based on payroll taxes. We have a budget deficit that has been quite high lately. And we also have relatively high social charges on these payroll taxes. So it's not really possible to raise those rates on payroll taxes anymore. So what do we need to do? We definitely need to innovate. If there is one thing we need to achieve as a system, is innovation, because we will not be able to increase our budget at the same rate as demand for healthcare services and products is increasing. So we need to do things differently. We need to be able to predict when someone is going to get sick or how predisposed they are for a disease, and to identify them and contact them and try to serve them before they come into a hospital, which is the most expensive place to treat them. So this is one area of opportunity. Neonatal screening. In Costa Rica, back in March of 1990, we started screening 100% of all newborn babies against 51 genetic abnormalities. The criteria for what tests were run is that there had to be a treatment for these diseases. And this has been going on for the last 29 years. 100% of all babies for 29 years. So that means anyone in the country that's 29 or younger is in the database, but more importantly, their blood sample is in a biobank. So as sequencing costs come down, we're starting to ask the question, is it time to create a national genomic center where we can start to look at frequency of certain genetic mutations that might be linked to a cancer or a certain other chronic disease? Our system covers everyone from birth to death. So we are the most interested in identifying what are our future needs and investing in prevention. So this is one area of opportunity that we are just beginning to discuss, because we have what very few countries have, and that is an established large database of 29 years of 100% of everyone born in those 29 years and growing at another generation every single year. At some point, we'll have everyone in the database. A second recent development, and this is from last September, is we finally implemented our electronic medical record system in all of our hospitals and clinics in our institution. That is, you can go to any one of our over 1,000 primary care clinics or our hospitals and bring up your medical history and be seen by a doctor. And if you go to another clinic later, they will see what the last doctor prescribed as far as a pharmaceutical or what they diagnosed. And this is starting to create a very large database of information with which we can start to mine opportunities for intervening in prevention, identifying those patients that we can start to act on at a lower level, at a primary care level ideally, before they come to a hospital, once again, where it is most expensive to treat them. And I'll end with this slide. So our priorities in the healthcare system of Costa Rica are these four areas. We have to invest, but not just invest, develop the capabilities to promote health and to prevent disease. That's one big area. It's very medically based, very technologically intensive. Second, we need to provide timely and high quality services. Our system demands it, our population demands it, and if they don't get it, the court system will ensure that we have to give it to them in a timely manner. Third, sustainability of our Social Security system. We need to diversify our sources of financing. And fourth and last, innovation. Once again, we need to innovate in order to provide care in a different way. Our system was designed for another time, for another population, for another burden of disease, for another average age expectancy, for other diseases. We have very different realities today, and so we have to innovate. If there is one thing that we need to leave behind in this administration, is a culture of innovation in this very large and complex system. Thank you.